Hello everyone. Today we are going to discuss about the topic Pheochromocytoma. Before that, we have to discuss what is kidney and what is adrenal gland. So here we can see the dissection of adrenal gland. There is a cross section of that gland, and the layer of this adrenal gland, it's cortex, medulla, and the capsule. Medulla is the innerst, and cortex then outer. The outermost is capsule. So I will discuss the layers of cortex. Cortex have three layers: zona glomerulosa, fasciculata, reticularis. So first one is soma glomerulosa. What is zona glomerulosa? This is the outermost layer of the adrenal cortex actually. This is the outermost layer of adrenal cortex. And what it produces is mineralocorticoids. Zona glomerulosa is producing mineralocorticoids. I will give you one example of this mineralocorticoids is aldosterone. Aldosterone is the example of mineralocorticoids. Is essential for fluid and electrolyte balance. Then the second layer is fasciculata, zona fasciculata. This is produce glucocorticoids. Mainly, I will give you one example for glucocorticoids also. The main example is cortisol. This cortisol is regulate the metabolism of glucose in our body actually. So main function is that, and I will explain you one topic here. Increase or excess cortisol level will lead a syndrome called adrenal Cushing syndrome. The problem is in our body, the excess cortisol will lead to adrenal Cushing syndrome. In here, I will explain you one more thing. One more syndrome, a genetic disorder, McCain-Albright syndrome. Actually, this syndrome can also present as Cushing syndrome in affected patient. Actually, there is a triad for this McCain-Albright syndrome. I will tell you that triad also. This is also important. First, precocious puberty. The first triad is precocious puberty, cafe au lait spot. I will show you cafe au lait spot in a diagram. It's a skin discoloration, brownish spot-like discoloration. Here it's go. You can see the skin coloration is different from the normal color. So these spots, these brown-like spots we can call cafe au lait spot. This spot is present in McCain-Albright syndrome. And the third triad is polyostotic fibrous dysplasia. Polyostotic fibrous dysplasia. These are the three triad for McCain-Albright syndrome. I just tell you this for a new information here. It's not a topic from the Pheochromocytoma. So the next layer is reticularis. So we discussed glomerulosa, fasciculata, and we are going to the next layer. The innermost layer is reticularis. This is very important that this produce our sex hormone. Very important. This reticularis is producing sex hormone. Okay, this is the outer layer of this topic. So we can move to Pheochromocytoma. And we can start what is Pheochromocytoma, what condition is this. So let's start Pheochromocytoma. I already told that we have a medulla which produce catecholamines. What is catecholamines? Catecholamines are epinephrine and norepinephrine. Two catecholamine examples are epinephrine and norepinephrine. Here, the problem is the medulla is producing more and more excess amount of catecholamines or epinephrine. This will increase our systemic system. This will increase our sympathetic system. Sympathetic system means the heart rate will increase. Everything is increased. The sympathetic is running mode. Like we are running, and that time what happened in our body, that all is happening by sympathetic nervous system. And this here, the increased epinephrine will lead to increased sympathetic system. So definition is catecholamine secreting tumor formed by chromaffin cell within the adrenal medulla. What is the definition of pheochromocytoma is catecholamine secreting tumor formed by chromaffin cell within the adrenal medulla. Here it's the definition of pheochromocytoma, and it often in mostly it's a single tumor. Mostly it's a single tumor, and 10% only it's malignant. So the chances of malignancy is 10%. I can tell you here one more point, that it is actually a similar presentation to one symptom or one case. So the similar to paragangliomas. Actually, these paragangliomas are originate from the sympathetic nervous system, and our pheochromocytoma which originate from the adrenal medulla. But the symptoms are same. In both cases, the sympathetic system is excessing or rising. The symptoms are same, almost same. The treatment also similar. So here you have to understand that these two cases, paragangliomas and pheochromocytoma, the symptoms are same. The origination is a little bit different, but the treatment also almost similar. Then we can move to etiology. Like etiology is most cases, most common is idiopathic. The most common etiology is idiopathic. We don't know the reason. And in few cases only, it's rarely genetic, which is associated with some gene, genetic disorders. It's very rare, and it is associated with MEN2A, MEN2B, and von Hippel-Lindau. What is MEN2A and MEN2B? Anyone knows about this? MEN2A or MEN2B? Yes, it is a multiple endocrine neoplasia type syndrome. So this is a genetic disorder. It's not common in pheochromocytoma. For common etiology is, of course, idiopathic. In some cases, genetic. So MEN2A and MEN2B is multiple endocrine neoplasia type syndromes. So we can move to pathophysiology. Fine. Pathophysiology, it's interesting. Here my drawing is not good enough. This is our adrenal gland. This is the inner side. So this is cortex, and this is medulla, and this is our tumor presenting inside the adrenal gland. Normally, this adrenal gland produce epinephrine and norepinephrine, but here it's a big tumor is present. So big tumor will produce excess amount of epinephrine and norepinephrine. So production of epinephrine and norepinephrine is excessively producing here. So this catecholamine will act on adrenergic receptors like alpha-1 receptors. There are some adrenergic receptors. First one is alpha-1 receptor. So this alpha-1 receptor will act, this will contribute the vasoconstriction and smooth muscle contraction. So vasoconstriction and smooth muscle contraction. Vasoconstriction leads to increased blood pressure. So in this case, the patient blood pressure is always high. And second, it will act on beta-1 receptor. beta 1 receptor present in heart, and this will increase cardiac output, increase heart rate also, increase heart rate, we can tell tachycardia, and increase stroke volume. So beta 1 receptor will increase these three things in our body: cardiac output, heart rate, and stroke volume. And then will act beta 2 receptor also. This is present in the lungs. So this will increase the smooth muscle relaxation in respiratory system. Wow. So this three things you have to notice here, from where it is acting and what conditions and what symptoms are showing up. First, alpha 1 receptor, beta 1 receptor, beta 2 receptor, and so on. We'll discuss about some triad here. So pheochromocytoma have a triad, same like Albright syndrome, but the triad is different. First triad is episodic pounding headache. Episodic pounding headache. Second is palpitation and tachycardia. We already mentioned that beta 1 receptor will increase heart rate and tachycardia. So palpitation and tachycardia. Third one is diaphoresis. Diaphoresis is increased sweating, the excess amount of sweating in the body. So this is the triad for pheochromocytoma. Let's move to investigation. Here you have to understand one term or one sentence. Before investigation, if patient is taking any interfering medication, before investigation, if patient is taking any interfering medication, should discontinue. Mark this word. Any medication, interfering medication is taking, you have to discontinue this. One of the example of such medication is tricyclic antidepressants. All the antidepressants you have to discontinue before the surgery. Good to go? Okay. So what are the investigation we can do? We can do I will explain you two examples of investigation. First one is 24-hour urine fractionated metanephrine and catecholamines. 24-hour urine fractionated metanephrine and catecholamines. What is metanephrine? Metanephrine, nothing, it's a breakdown product of catecholamine. Okay, it's a breakdown product, it's nothing more. So this is the first investigation we can do. And also we can do plasma fractionated metanephrines. This is also an investigation method. Fractionated metanephrines we can diagnose from the plasma. So these two are the investigation we can do. And also treatment, it's important. Also treatment is of course surgical resection. There is nothing more or less, but here also you have to understand, before surgery we have to do some protocols. So surgical resection, before surgery, do pre-operative, some medications you have to give. So pre-operative alpha adrenergic blockade, then beta adrenergic blockade. This is the main point here. We have to give the patient before surgery alpha adrenergic blockade, then after that beta adrenergic blockade. Very important. Before surgery you have to do this. So alpha adrenergic blockade, how many days before we have to start this alpha adrenergic blockade? Yes, 10 to 14 days before surgery. 10 to 14 days before surgery, you have to give this medicine to the patient. Give me one example. Phenoxybenzamine. Phenoxybenzamine is the drug we can give, but also one more thing I will explain you. But daily BP monitor. You have to monitor BP. Daily BP monitoring and high sodium diet. High sodium diet. How much level? More than 5 gram per day. More than 5 gram per day. Here I will tell you one more important thing. Sometimes, if required, the patient need long-term alpha-adrenergic blockade. I will tell you more than 14 days. If the patient want this medication, then don't give phenoxybenzaimine. Then give prazosin, terasocin, doxazocin. These medicines are useful for long-term treatment. What are the prazosin, terasocin, and doxazocin? These are more selective drugs. So more than 14 days treatment, use these drugs in place of phenoxybenzaimine. These are more selective drugs. And we can give then beta adrenergic blockade. I told you first alpha adrenergic blockade, then beta adrenergic blockade. So give me one example. Yes, propranolol. Propranolol is the beta adrenergic blockade. Here one more note you have to mention. There is a drug, methyrosin. There is a drug called methyrosin. It is a catecholamine synthesis inhibitor. It is a catecholamine synthesis inhibitor. This we can't give in the first stage. Only when other therapies are ineffective, start with this methyrosin. These are the treatment, and we almost covered the topic etiology, pathophysiology, and clinical triads. Here we already discussed and all blah 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 things. Okay, you understand the outlier. So we are finishing this pheochromocytoma. Hope you all understand this topic, and thank you very much. And we will see you soon with any other topic. Thank you.